have talked about the CNS complications in sickle cell disease, and of course CNS involvement is most common in stroke. And it's been said in the literature, and perhaps there is, of course, compared to the CNS, truth in this, the extensive peripheral nerve vascular supply and large capillaries could possibly explain why ischemic neuropathy is considered to be rare in sickle cell disease. Of course, this is dogma, and we're here to learn and go forward from this statement. The known types of pain in patients with sickle cell disease include the recurrent vaso-occlusive crises, persistent pain between crises, and chronic pain, pain due to therapy. I gather hydroxyurea is not associated with neuropathy or painful neuropathy, but there may be issues in this regard. Pain due to comorbid conditions, and a phenomenon called opioid hyperalgesia. And again, this is all nicely reviewed by Deepika Darbari, who gave an excellent talk yesterday in this review. And we know that pain in sickle cell disease is likely to be complex, and indeed there is a significant overlap between so-called nociceptive and neuropathic descriptors of pain in one study in sickle cell disease. I'll just briefly recap for those who weren't at the Parallel Symposium yesterday that there have been some studies in peripheral neuropathy and pain in sickle cell disease. A study from Turkey in 51 patients showed that peripheral nerve system involvement with nerve conduction studies was in about 20% of patients. The frequency of sickle cell crisis was not significantly correlated with peripheral neuropathy. In Nigeria, in 62 patients, 44 out of 62 had abnormalities in 2 out of 5 tests to detect cardiovascular autonomic neuropathy. And in these cases, there was an association with leg ulcers, postural dizziness, erectile dysfunction in men, and these were found to be more common in the patients with the, not surprisingly, with the cardiovascular autonomic neuropathy. And Mendes in Brazil, for example, in a cohort of normal subjects as well as SCD, showed a higher prevalence of mental nerve neuropathy, a kind of mononeuropathy. It was more frequent amongst females and in older subjects, a recurrent theme, as you will see. I want to just briefly mention this one case report because it illustrates mechanisms in a very dramatic way. This is, in fact, from my own hometown of London. A 19-year-old woman, severe pain in the waist, realized she could not feel or move her left leg, confirmed by neurological examination to be a neurological problem. CNS investigations, imaging, vascular were normal. She had emergency automated red cell exchange transfusion. 24 hours after presentation led to immediate clinical improvement with almost complete resolution of deficit, confirmed by the neurologist there, who I know well. And she was discharged home 48 after admission without any neurological deficit. I mean, this is kind of a miracle in the world of neurology, if you like. And it suggests that there may well be here prolonged nerve conduction deficit, not only in the acute stage here, but as we will discuss in the chronic stages. Neuropathic pain in SCD has also been studied using a questionnaire, 56 patients, called Pain Detect, developed in Germany. It is a validated tool. It's now considered to be the most important validated tool in detecting neuropathic pain in either possible, probable, or definite. And in the probable and definite categories, 37% of these patients had evidence of neuropathic pain. Again, age and females seem to be more common. Interestingly here, more patients with neuropathic pain were taking hydroxyurea, 90% versus 59%, but of course this could just simply reflect the severity of the condition and not a neuropathy caused by hydroxyurea, and only 5% were taking a neuropathic pain drug. So the conclusion as opposed to 37 patients who had evidence of neuropathic pain, an unmet need, unrecognized need. Their conclusion was neuropathic pain exists in SCD, full stop. We need to identify patients that would benefit from neuropathic pain therapies. We've heard about how do you detect it, and there have been some studies in sickle cell disease using QST, so-called quantitative sensory testing. One study found in children, they had hypersensitivity to thermal stimuli. Another study did not find a change. Transgenic mice do show changes with hypersensitivity that Dr. Gupta's group has shown to cold, heat, and mechanical stimuli. But as Dr. Nitya Bakshi's presentation yesterday indicated, you both have changes of elevated as well as lower thresholds. It's sometimes very hard to interpret them. And there are issues, therefore, because if there's cognitive involvement, because these sensory tests require an explanation and understanding of the test, it may not be possible to get reliable data. And indeed, there is no reliable control data in many of these populations. So it comes to this, that here is your so-called prevalence chart wheel of neuropathies. You can see sciatica is the greatest, diabetic neuropathy here. SCD isn't here, but perhaps in the future with collaborations we will put it on this wheel. The epidemiology, therefore, learning lessons from diabetic neuropathy, which is now the fastest growing neuropathy in the world, a lot of money, resources all over the world, including Europe and the USA, are being put into this because diabetes is increasing, so is neuropathy. But you can see here the prevalence amongst diabetics is 40 to 60%, and from and we know from one of the studies I've shown you that it may be in sickle cell disease greater than 20%. Neuropathic pain occurs in diabetics 10 to 16%, and if you believe that one pain detect study, it's 37%. Aging is really a feature in diabetics. In fact, aging simply reproduces what we see in diabetic neuropathy. So in other words, diabetes is simply producing damage to nerves earlier than they would with aging after we cross 75 years of age. It's not more common in males, but alcohol is a comorbidity factor both in the UK and in Nigeria. Autonomic neuropathy prevalence in diabetes is 20%. You can see if that one study can be replicated, it's 60% in sickle cell disease. And autonomic neuropathy relation to the duration of diabetes not established, associated prognosis. So this is, again, something that should be recognized. The other lessons from diabetic neuropathy are that the incidence, prevalence, and diagnosis depends on definition, what tools you use. One classification is a so-called rapidly reversible phenomena, distal sensory symptoms, i.e. pain, numbness, reduced conduction velocity, slowing if you like, and conduction block. And the case that I described to you from London may have shown all these features. Yep, reversible phenomena. In contrast, established neuropathies, these could be the so-called chronic sickle cell disease cases. They are related to the focal and multifocal neuropathies, for example, cranial neuropathies, the mental nerve, if you like, incidents I talked about. Again, that lady who had the weakness of the leg, this is a more chronic form of the same thing, established. And then you have symmetrical polyneuropathies, as we say. 70% of all neuropathies are these, and they have variable sensory changes. We'll have numbness and pain in the same area. Seems counterintuitive, but it's actually the hallmark of neuropathy. And note that underlying neuropathies, so like diabetes, diabetic neuropathies, many different neuropathies. And in sickle cell disease, you will find many peripheral neuropathies. Okay, this is a patient of mine, red feet, burning, swollen, etc. And my differential diagnosis came on a stretcher with a bag of ice, couldn't bear to touch anything, red, swollen, etc. My differential diagnosis would be early diabetic or Charcot, just looking at the picture, of course. I know nothing about the patient. Say, query, vasculitis, neuroinflammatory, query NAB 1.7 gain of function mutation, query non-freezing cold injury or trench foot. But since I came to this meeting, I now know that there may well be something else going in the minds of the clinicians here if this was a patient with sickle. But I need to do the tests to find out what this patient has in terms, quite apart from the diagnosis, the underlying condition, but in terms of how to characterize this and what are the underlying mechanisms. And the same needs to be done for your patients at the early stage, going from the acute stage to the chronic stage. And in yellow, I've put in all the things that some people have done in sickle cell disease so far. In white are all the things that we do routinely in the clinic. And note that the three main things that are objective, sensitive, and the gold standard, skin biopsies, skin flare responses, and evoked potentials, fMRI, sensory stimuli, PET, etc. None of these have been done in sickle cell disease. And if you think this is difficult to do, I did a leprosy project. We published in Brain in Pain 15 years ago in Bombay, in collaboration with Dr. Sickle, and we did everything except for H and except for the pain-related, specific pain-related genes, NB1.7, and pain-related inflammatory markers, voltage-gated potassium channel antibodies. So this can be done. It's been done in Mumbai, it can be done here in Bhubaneswar. And so this is briefly what these tests are. These are pain evoked potentials. It's like doing an ECG with scalp electrodes, and you stimulate the area. The time it takes to put the electrodes is the main time. You could set it up here in the corner of the room and do it in 20 minutes. Yep, so it's quite easy to do. And you can see here you get face, arm, leg evoked potentials, these are A delta potentials or recorded over the scalp. And here in a patient who presented with burning red feet, similar to the one I showed you, who had at that point, you could see immediately that these face, arm, and leg, the amplitudes were reduced. The skin flare area was reduced. And then on skin biopsy, these are 3 millimeter skin punch biopsies, very easy to do under local anesthetic. There's no problem with healing, even in diabetics. You can see decreased numbers of intraepidermal fibers to controls. So what is happening with fewer fibers, but pain at the same time, is that nerve injury leads to decreased density of cutaneous nociceptors. They receive more than their fair share of neurotrophins, the growth factors that regulate the sensitivity in development and adulthood and maintenance, and cytokines, the residual nociceptors, residual fibers. These lead to activation of these residual fibers, retrograde NGF transport, P38 myokinase activation, which we know happens in sickle mice from yesterday, increased excitatory proteins, hyperexcitability, topic discharges, and pain. And so this is a cartoon which shows you, here's your target organ skin. In dots are your growth factors. They're taken up to the cell body, make them healthy and happy, send down proteins like sodium channels, TRPV1, chili pepper channels, and these are activated and produce normal sensation. What happens if you get shingles? It's a ganglionitis. You lose half of them. Now, fewer fibers receive the same number of growth factors, and they become hypersensitive. It's a bit like the cake remains the same. The number of the people come to the party are half the number. They eat too much cake. They eat twice the amount of cake. They get sick. They throw up and complain. Pain. And in diabetic neuropathy, dying and going back neuropathies and chronic occlusive reperfusion neuropathies may be the same, say in sickle. This is a dying process, and these now contact blood vessels, as I'll show you, and the blood vessels may be abnormal, and again, these are hypersensitive. I won't go to the deniers. So we know about nerves having good supply, but the target organs don't. And we know the target organs are damaged in sickle cell disease, and this hasn't been looked at. So quite apart from looking at nerves in your skin biopsies, you can see here pain. It seems to have disappeared off the screen there. You see increased vessels in those patients who have pain as opposed to non-painful neuropathies or diabetes without neuropathy or controls. So in other words, these, and you can see this is not just the von Willebrand factor as a marker, but also eNOS and VEGF, suggesting these are regrowing vessels, and the nerves growing along them, we've shown, receive more than their fair share of growth factors, you produce pain. And we can trim these nerve endings and see whether we can get benefit in a simple way. In terms of treatment, in the UK, NICE recommends for neuropathic pain conditions, amitriptyline, duloxetine, gabapentinoids, topicals like lidocaine and the capsaicin 8% patch, which if we've got time, I can perhaps talk about pain relief with disease modification in chemotherapy-induced painful neuropathy. The same may be done in diabetics and indeed in other conditions. It doesn't require the special expensive patch. You can make it up in your pharmacy and give it over 3 days under an inclusive dressing. Opioids are reserved for the extreme intractable cases, but are given in combination. And I know that there have been reviews on opioid analgesia. Many people have talked about it at this meeting, so I will not cover that, all the issues related to that. But of course, many of our patients receive neuromodulation, say spinal cord stimulation, and before that, other things like cognitive behavioral therapy, etc. So in conclusion, in terms of this part of the talk, neuropathic pain certainly exists in spinal cord disease and sickle cell disease, need to identify patients that would benefit from neuropathic pain therapy, because with Pain Detect, 37% had probable neuropathic pain, but only 5% were receiving neuropathic pain treatment. Objective measures required for accurate measurement of prevalence and clinical diagnosis, particularly skin biopsies. QST is helpful, useful, but as I say, particularly in children, there are problems if there is a cognition deficit. If the child is 5 or 6 years old and is mentally okay, they love doing QST. They do it as better than adults. And it's certainly possible to do. We did a study in obstetric brachial plexus palsy patients, all the way from the age of 3 or 4 up to 20, and with controls and the other areas of their body, and it was a study that was very easy to do. So it certainly can be done, but in the case of sickle cases, I hear yesterday that this may be an issue in terms of the CNS involvement. Skin biopsies get around this. It's objective, and it's simple to do, and it's really not an issue. We do them in children, in the channelopathy cases that I described. These will tell you more accurately the prevalence and also help with diagnosis in terms of, is it neuropathic pain? Is there a neuropathic component to the pain? And so what we've described as kind of painful vasoneuropathies would be advanced diabetes, where the fibers have degenerated to the vessels, so-called non-freezing cold injury or trench foot, again, where you have vasoconstriction, hypoxia, and then relief and redness as the blood flow reappears, a kind of reperfusion injury. And indeed, Frank Rice, my friend in the USA, has shown that there's increased innervation of the blood vessels, particularly in the muscles, in patients with fibromyalgia. And he proposes this is why you get muscle pain or deep pain. And again, muscle biopsies may be useful in sickle cell disease. In other words, do they have a neuropathy, which is really a painful vasoneuropathy? And then finally, novel agents are required for specific prevention and treatment of pain in sickle cell disease. For example, NOP, or nociceptin receptor agonists, which Dr. Gupta again has shown in sickle mice to be effective. Now, this has not come to the clinic yet, but this may be as effective as morphine in animal models and in vitro, but does not have the CNS or PNS issues associated with MOP, which is the morphine receptor agonist. So in other words, you don't have liability addiction, you don't have constipation, respiratory failure, all the associated things. Now, we have got a little bit of time, so I'm just going to spend the next sort of 4 or 5 minutes telling you about a capsaicin 8% patch. So I didn't bring dance to Odisha, but I'm bringing capsaicin to chili peppers to India. So capsaicin is the only molecule that's the active ingredient of chili peppers that makes them pungent and hot, and it acts on a receptor called TRPV1, which is the only molecule in the body that can react to capsaicin, and it's present in about 80% of our so-called pain fibers, nociceptors, that normally feel heat, but also are activated by chilies, which is why chilies feel hot. They don't change the temperature of your mouth. They activate a receptor which is normally activated by heat. Similarly, when you brush your teeth in the morning, it feels cool. The mint, which is acting on the TRPM8, its sister, which is normally activated by cooling, is causing the sensation, which is why you pay more for your toothpaste with the signal. It gives you a positive signal. It's a sister of the chili pepper receptor, if you like. Yeah? And we've known for ages with topical creams, low-dose capsaicin creams, that if we apply it to the skin, initially you get no pain, then you get mild irritation, pain or burning, then you keep applying it, you get intense pain, and eventually you get no pain. With the low-dose creams, 0.075% or 0.1%, it takes you 2 to 6 weeks, applying it 3 to 4 times a day before you get to this point. And in the meanwhile, you get in your contact lenses, your bedclothes, etc., etc. It's not very, if you're walking around the day, you can't apply it 3 or 4 times a day, your shoes and socks back on. The capsaicin 8% patch, which is much higher, does the same thing, but it does in 36 minutes, actually just 30 minutes. So you apply it as a patch called Cutenza. It's available in the USA for post-operative neuralgia, in Europe for all neuropathic pain. And the patient is there lying on the couch, you put the patch on, you put a cooling pack, take it off, they go home. And it does the whole thing just in 30 minutes. And you can do it, you can make your own patch. You don't need to buy it. It need not be expensive. And what it does, it enters, capsaicin enters through the trip channel, just the nociceptors, and they degenerate reversibly up to a certain depth. Yeah? And it poisons the mitochondria up to that certain point, but only in those pain fibers. And after 2 to 3 months, they regrow. Yeah? So it's a reversible retraction of peripheral nerve terminals, and these are no longer hypersensitive. And when they come back, sometimes they branch, they do better things, especially if the target organ is now healthy and happy, like in diabetics, for example, who are under better control, or patients with chemotherapy who are not receiving chemotherapy anymore, which affects the nerve fibers and also the skin cells, your keratinocytes, etc. And here you can see in diabetics, 90 cases, 3% didn't respond, 28, 1/3 no response, 1/3 had the usual response, and came back in 12 weeks, but 1/3 of patients, the pain never came back. And in a safety study, we applied it every 2 months for a whole year. This is capsaicin with standard of care, and this is standard of care alone in diabetics. The pain goes down, 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 down. We don't know why, but we think it's the ratio of the fibers to the nerve, to the blood vessels, the keratinocytes, that is being changed. And we are going to do skin biopsies in this cohort, which is a very large cohort of several hundred patients, to find the mechanism. We have done a study in chemotherapy-induced neuropathy. These are patients with chemotherapy-induced neuropathy in remission from cancer. They've got persistent pain. And we did the patch one occasion, looked at the skin biopsies 3 months later. Okay? So one application for 12 weeks, all the pain scores were down, patient global impression of change, as you might expect in large-scale styles. This has been confirmed. Skin biopsy showed increase in number of the nerve fibers. In the epidermis, the so-called nociceptor fibers, and in the subepidermis, they had come back to control levels, and they had gone up as well. Regenerating fibers marked by GAP43, which is a specific protein in regenerating nerve fibers, was also increased. So essentially, what we were doing was we were pruning the terminals here. This is something taken out of an agricultural journal. And this is what we do at a certain point, and then this leads to new shoots and regeneration of good fibers. So this is what we do in the autumn in the UK, and in the springtime, when the milieu is better, when occasionally we do see the sun and we do see warmth, and so do the roses. And now, instead of the twiglets, the little branches that are pokey, etc., painful, we now see leaves and flowers. These are the receptors that are required for normal sensation. So what we have here is disease modification, both improvement of sensation and relief of pain. It remains for me to thank my colleagues who have helped with all the studies at Imperial College London and Hammersmith Hospital, and my oncology and indeed hematology colleagues, because many of my colleagues who treat myeloma have referred patients for the Cutenza patch, and this is now quite routine. I tell them we've actually finished the project, but they still say, for your project, we are now referring you this patient. So it's a service we provide. And Keith Bly, who invented the capsaicin patch, is a friend of mine in San Francisco, Roche Palo Alto, a company called Neurogesics. And so thank you very much.